I'm delighted to introduce Monika Mann. She's been an active member of HVO for many years. She's served as a project director, as a volunteer overseas at projects in Ethiopia, El Salvador, and Vietnam, and was the technical expert for a USAID-funded rehab grant that we had in Rwanda several years ago. She's currently a member of the PT Steering Committee and is involved in some virtual volunteering activities with HVO in Peru and Guatemala. She's served as an independent consultant to the World Health Organization and the Pan American Health Organization, where she worked on strengthening the rehab sector in health systems. She also consults with World Physiotherapy. She is an associate faculty member with the Department of International Health at Johns Hopkins Bloomberg School of Public Health as well. And with that, welcome, and I turn the meeting over to Monika.
Hi there. I hope you can see me okay. I'm still seeing Nancy on my screen. Can you see and hear me okay?
Yes, I can.
Hello. Great. Wonderful. Okay, so I'm happy to be here today to talk to you about Rehabilitation 2030, which is WHO's initiative for strengthening rehabilitation in health systems. And I am going to go ahead and share my screen with you all. And we'll get right here. Pull this up. Great. Okay. So let me get this low. All right, so we're going to talk about WHO's Rehabilitation 2030, and I want to talk a little bit about what it is and how HVO can align with its goals and the initiative. And we'll start by looking at just a short look at its history and how and why it came about. Let's see here. So let's see if this is going to go for me there. Okay, so a little bit about the background. So Rehabilitation 2030, let me go back here. In February of 2017, WHO hosted its first meeting called Rehabilitation 2030, a call for action. And this was attended by over 200 rehabilitation experts from 46 countries. And it really highlighted the need for physiotherapy and other rehabilitation services throughout the world. And what it looked at was that there's a growing and unmet need for rehabilitation, especially in lower and middle income countries. So I want to go over with you a little bit why that is, why now there is a growing and unmet need for rehabilitation services. So let's take a little deeper dive into that. And we can see, first off, there's taking COVID aside, which is we're in an unusual pandemic situation here, but in general, there's a decrease in infectious diseases globally. And this is a result of, really successful public health efforts in sanitation, in looking at vaccinations, and other campaigns that have been successful in decreasing infectious diseases. Okay. And let's move ahead here. But at the same time, there's been a slight increase in injuries, and this is primarily driven by motor vehicle injuries with more people driving, right? And the big reason for the increased need for rehabilitation, there's two of them. One is the increase in non-communicable diseases, and that people are living longer. Okay, so why is there an increase in non-communicable diseases, especially in lower middle income countries? And part of that's due to a demographic shift, which means that people are moving to urban centers and out of the rural sector. And with that, they're tending to take more sedentary jobs, have more of a sedentary lifestyle, not eat as well as they did in the rural areas, right? Not get as much exercise. So some of the same issues that we're having. So increased obesity throughout the world and all of the non-communicable diseases that come along with that. So those are some of the reasons for an increase in non-communicable diseases. And also we're living longer. And we know that as people age, there tends to be an increased need for rehabilitation services. So here's a screenshot just showing the causes of death, the top 10 causes of death in 2019. And if you look at the blue dots, those are all non-communicable diseases. So you can see that out of the top 10 causes of death, 7 are due to non-communicable diseases. The 3 that aren't, 2 of the 3 really have to do with neonatal and pediatric issues. There's diarrhea diseases, which is more pediatric, as well as neonatal conditions, and then finally lower respiratory infections. And those are the only 3 of the top 10 reasons for mortality globally that are due to communicable diseases. Okay. So in the plan in 2017, WHO developed a strategic and coordinated strategy to strengthen rehabilitation within the health system. And they wanted to emphasize that rehabilitation is relevant to the whole population, across the lifespan, and throughout the continuum of care. And the reason that these 3 issues were highlighted is that often in lower middle income countries, rehabilitation is still equated with the needs of just people with long-term disabilities. It's thought of as a niche sector, and that it's not relevant to the entire population. And we all know as rehabilitation professionals, it is relevant to the entire population. If somebody sprains an ankle, hurts a back, orthopedic issues. So trying to drive that through to the population and the health system, they realize that. Also, in some areas, rehabilitation is thought of as maybe just needed in pediatric and geriatric sectors, and we want to emphasize it's throughout the lifespan and throughout the continuum of care. And what that means is throughout acute care, subacute, chronic care, as well as throughout primary, secondary, and tertiary care facilities. So some of you that have worked with HVO may have gone to countries where if you're working in a tertiary care facility, which would be like a big referral hospital, they might have a pretty good rehabilitation department. But if you dig further and look into secondary care and primary care settings, there isn't as much rehabilitation, or there might not be any. So we're trying to strengthen rehabilitation throughout all the levels of care and throughout the continuation of care. Okay. So again, the point is rehabilitation isn't just for people with long-term disabilities. It's for all health conditions causing limitations in functioning. And it's important to emphasize that in order for health systems to prioritize rehabilitation, right? So it's not just thought of as only being needed by a small sector of society. Okay, so in some, Rehabilitation 2030 indicated that rehabilitation is a mainstream health sector and should be available at all levels of healthcare. But the problem is there's often a lack of funding for rehabilitation, a lack of available services, a lack of needed professionals, a lack of prioritization, and a lack of awareness about rehabilitation. And this is true not only in the general population, but within parts of the health system, the Ministry of Health, or other professionals, physicians, nurses, other healthcare professionals that don't really understand the scope of rehabilitation. So what we have is we have a high need for rehabilitation. And this is kind of an interesting situation because there's a low demand. So usually when there's a high need for something, there's a high demand for it. We know there's a high need for rehabilitation. We can look at statistics on injuries and on neonatal issues and disabilities. So we know there's a high need, but there's a low demand. So why is that? There's usually a lack of awareness and a lack of advocacy, right? So a lack of awareness among both the general public and healthcare professionals about rehabilitation, and a lack of advocacy. So to advocate for timely and appropriate referrals to rehabilitation services. And there's a lack of supply. So there's a lack of supply often of adequately trained rehabilitation professionals throughout countries. Sometimes there's enough in urban sectors, but not in rural sectors or in other areas that need rehabilitation professionals. So WHO has adopted a dual strategy to increase demand and a decreased supply in order to meet the need of rehabilitation. And that includes awareness and advocacy, as well as technical capacity. The availability of affordable and accessible rehab is necessary for many people to remain as independent as possible and function at their highest level. So two key words here are affordable and accessible. We often see that rehabilitation is available for instance, if people pay out of pocket going to private practices, or is available in densely populated area, but it's not available throughout the health system and in areas that more remote areas. So we're looking at trying to increase affordable and accessible rehabilitation. WHO really wants to emphasize functioning as the third health indicator. So we usually think of the two main health indicators, which are morbidity, illness, and mortality, death, right? But the third health indicator is functioning. So mortality tells us about the length of life, right? But functioning tells us about the quality of life. And this is what, of course, rehabilitations are most, professionals are most appropriate to work on, is increasing the functioning and quality of life, which is so important now that people are living longer. So in sum, the Rehabilitation Initiative, there's 3 points, Rehabilitation 2030, there's 3 points. One is that rehabilitation is an essential health service and crucial for achieving universal health coverage. Efforts to strengthen rehabilitation should be developed toward supporting the entire health system as a whole and integrating rehabilitation into all levels of healthcare. And rehabilitation should be available for all the population through all the stages of the life course. So that was the initiative from 2017. And then in 2019, there was a follow-up meeting at WHO headquarters in Geneva, which called together rehabilitation specialists throughout the world. I think I'm right here front and center pretty much. And so this is WHO headquarters. And it was really to look at what had been achieved in the following in the past 2 years on the initiative, and then building out more strategies to strengthen the initiative in the future. And the meeting emphasized 3 tools that WHO has been working on and has introduced in the last few years. And I want to take some time to go over those 3 tools, and you may be familiar with some of them. The first one's the Rehabilitation Guide for Action in Health Systems. The second is the Package of Rehabilitation Interventions. And the third is the Rehabilitation Competency Framework. Okay, so we'll talk first about the Rehabilitation and Health Systems Guide for Action. And what that is, it's a 4-step process to strengthen rehabilitation in countries. It includes assessing the current situation, establishing a strategic plan, developing a monitoring and evaluation framework, and implementing action steps. So how this works is that countries ask for assistance from WHO to strengthen the rehabilitation sector. And then WHO sends a consultant to go to the country, usually spend about 2 weeks in the country, talking to leaders in rehabilitation, other stakeholders, users of rehabilitation services. So conducting in-depth interviews, site visits, there are looking at background information papers, strategic plans that are already in place in the health system, including rehabilitation. And there's a involved questionnaire that leaders in rehabilitation fill out about some quantitative numbers about rehab. So at the end of that site visit, there's a rehabilitation technical group that comes together of rehab leaders in the country, and there's a meeting. It's usually an all-day meeting where a SWOT analysis is developed to look at the strengths, weaknesses, opportunities, and am I forgetting that? And I'm forgetting, but to look at the strengths and weaknesses and challenges of rehabilitation in the area and in the country, and then talk about the next steps, which should be strategic planning. So after that meeting, after that 2-week period, there's a report written up, and then the country determines if they want to move forward to working on a strategic plan with the consultant. If that's the case, the consultant returns to the country and works with a technical working group to develop a strategic plan, but not just hope that the idea is not to have a nice looking plan that sits on a shelf, that often happens, but to develop at the same time a monitoring and evaluation framework, and then to look at action steps that will, to continually monitor and evaluate those action steps to see if they're reaching the goals of the plan. So those are the 4 steps, and there's quite a few countries that have already taken advantage or are in the process of going through those steps. I worked in both Guyana and Zambia on these steps of the Guide to Action. And this is just an example. This is in Zambia in the rural areas. So I'm here talking with community rehabilitation workers about what they're doing, what the needs are in the rural areas, strengths and weaknesses. So just gathering information with them with a focus group discussion. Okay. So step 2, remember there's 3 tools. So the first tool is the Guide to Action. The second tool is the Rehabilitation Competency Framework. And that was just rolled out last month. And there've been some, WHO has had some meetings about it. Some of you may have attended. There's another one coming up if you're interested. We send you out information on that. And it's a framework to ensure that rehabilitation workers have the competencies necessary to deliver quality rehabilitation interventions needed by their populations. So essentially, often when we're talking about strengthening work sectors, we think about the numbers of professionals needed or the numbers of workers needed. But what the competency framework looks at is not the numbers of professionals, but the quality and the competencies of those professionals. And what the framework is, it looks at, it's a big document looking at all sorts of competencies in rehabilitation, and then they can be assessed on a scale of 1 to 4. 1 is if somebody isn't able to do something, 2 is if they need help, 4 is if they can teach it, 3 is if they do it, on and on, if they can do it independently, more or less. So that's what we're looking at. And the way it works is that countries can look at that template, and there's an adopt and adapt approach. So what it means is you adopt the template and then you adapt it to your setting. So for instance, some countries aren't interested in competency in dry needling, or if everybody can do research. So they just pick out the indicators they want to use and that they want to assess on their workers. So the users can create a content-specific competency framework based on the template of the WHO framework, so that it reflects the needs and priorities of the local population and the rehab community. The framework also, an interesting part of it, it was developed so that it can be used with any type of rehab worker. So it's not just for therapists or for physiatrists. It can be used too to assess what's going on with community health workers or people that are working in rehabilitation based in the community. So it can be used in all levels of rehabilitation care. And then the third tool is the rehabilitation packet of interventions. And that is is still in development, and it's going to be an open access online resource containing evidence-based rehabilitation interventions. And that should be rolling out later this year. Okay, so those are the 3 tools. And what I want to look at is how can health volunteer programs align a little more with the tenets of Rehabilitation 2030? Or if you're planning on volunteering or developing a program, how can you bring in a little bit of Rehabilitation 2030 to your program? So we know that HVO's strengths include teaching and capacity building of healthcare professionals globally, and that we have really great long-term international relationships and are respected in a lot of sites throughout the world. And that we have highly qualified volunteers going and teaching. Okay. But we want to look at how we can expand our programs a little bit to look beyond content-specific teaching and help drive strengthening of rehabilitation and health systems. So this isn't saying to change the whole mission of health volunteers overseas, but how in each program there could be, we could add a little bit of strengthening or helping the professionals we work with in strengthening rehabilitation within health systems. So I'm going to just give you a few ideas here, and we can discuss these later. And one is to really try to use a systems thinking approach. And what I mean by that, I'm going to give you a couple of examples. So here's an example. I'm going to put up what's called an intervention impact model on how to, and it's just a general kind of generic example of how to strengthen rehabilitation. So when we have these examples, we have targets, interventions, outcomes, and then impacts. What are we wanting to do, right? So maybe the outcome that we want is to increase rehabilitation referrals, right? And increase accessibility and utilization of rehab. So we get the referrals, but we want to make sure people can actually access that the rehab is accessible and that they actually go and utilize rehabilitation services once they get the referral, and that they get quality services, that they have improved outcome from rehab, right? That might be the outcomes we're looking for. And why? Why do we want those outcomes? Because we want to improve the functioning and quality of life for people needing rehabilitation services. So this is what do we want? This is why we want it. Okay, so how do we do that? What are the targets that we need to look at to do that? So one is the health system. We also need to target society or the general population and target professional education. So for instance, an intervention, oops, let's see if I can get this going, an intervention for the health system, and these are just examples in a country, an intervention might be to expand recruitment and training of community-based rehabilitation, CBR's community-based rehabilitation workers, where there's not enough rehabilitation professionals, to provide adequate staffing of rehabilitation professionals where available, and to train medical staff about rehabilitation. So those are ways that we could intervene in the health system. In society, people may need publicity about rehabilitation so people understand the scope of rehabilitation, so people are motivated to use the services. A sensitization campaign about inclusion and the rights and disability rights, and improved transportation. So improved transit accessibility for people who need rehabilitation. That can often be a barrier, like if somebody's using crutches, or also transportation is also a barrier because of the expenses of it. And then we need to look at professional education, right? And so we need to upgrade professional education programs, and increase the number and affordability of continuing professional development offerings. Okay, so this is where HVO comes into play, right? That we're really important in upgrading professional education programs, when we're working with faculty at programs, and offering quality continuing professional development classes. But you can see this is just one piece of the puzzle, right? So how could we just kind of expand out a little bit into these other pieces is the question. So this is still the goal, the main goal of HVO, but maybe in your class you could talk about, a little bit about advocacy, or how people can talk to other medical staff, or what they can do about publicity campaigns, or what they could do, something about leadership, or to improve outcomes, and looking at data. So there's other things we could incorporate into our classes instead of things that are content specific, but that also pertain to how we're going to get to this goal. Because I think this is really the goal we all have, no matter what we're teaching on, right? This is the impact we want. So how can we do that, expanding out a little bit from this traditional realm of HVO? Okay, let me see. I have one more of these I could show you. I know I'm running a little short on time, but I'll just show you another one really quickly. Here's another intervention impact model, which I think pertains to us a lot, is like how we introduce a new methodology into practice. So that's a lot of times what we're doing as volunteers with HVO is we want to teach something new, a new rehab intervention, a new methodology, a new way of evaluating people. Maybe it's person-centered practice, or evidence-based, or something new and different. So how do we introduce that? Okay. So let's look at this really quick. Again, we have the targets, interventions, outcome, and impact. Okay, and the outcome we want is acceptance, so adoption, penetration, and sustainability of the new methodology. Okay, and you can look up the differences of these. I think I'm going to go through this kind of quickly so we have enough time for questions. Okay. And then again, it's the same impact. We want improved function and quality of life for people needing rehab services. So usually who we target is clinicians and department heads, or rehab faculty, right? That's usually who we're teaching the new methodology, or what we're teaching our classes, the content. But we also need to look at the Ministry of Health, hospital administration, and the general population. So for an example, in Rwanda, we were trying to have people use outcome measures, and we taught it at this level, but the Ministry of Health and Hospital Administration hadn't bought into it, and we hadn't really talked to them about it, because we wanted them as part of initial evaluations and follow-up evaluations. Department heads also weren't always included, and they didn't always want people spending time on it or realize the importance of it. So we hadn't reached out as much as we could have at these levels. Okay, so let's look at what some of the interventions are. And then the general population needs to know why these things are important. Okay. So the intervention would be a comprehensive, contextually appropriate capacity building and sensitization of the use and importance of the new methodology, and regular long-term follow-ups. So for instance, I was just doing an evaluation of rehabilitation in Central America, and the general population, when they go to rehab, what they want, what they're used to and what they are expecting is hot packs and massage, right? So the general population then is an obstacle to moving forward with new, if we're teaching a new intervention, but people don't want that intervention, that's going to be a problem for us. So that's why we need to work at the general population areas level as well. Okay. So we talked about systems thinking. We also can look at advocacy, right? So I talked about that a little bit, but I think in many countries, people don't really know how to advocate for themselves, techniques for advocacy. So even, here in the United States, it can be daunting for me to call a physician and talk to her about changing treatment plan or something. So that can be hard to do, especially in your healthcare that's so stratified. So trying to talk about advocacy to strengthen rehabilitation is helpful to bring into courses. Also looking at the socioeconomic and geographical outreach of when you're teaching. So if you're just teaching in the capital, or just in of a country, you know, the capital city, or if you're just teaching in the tertiary hospital, to just question and bring up those questions to people. How are you going to spread this information, or try to set it up ahead of time, which is what we did in Rwanda. We made sure to move those courses. They weren't just in the capital, but and so people didn't have to come to them. We went and gave them at different sites. So we were more sure to reach the rural areas. Okay. We want to look at continuum and levels of care, and we've kind of mentioned that before. Make sure that, you know, people are lost a lot in, they get great care again in the hospitals, and then they don't get referrals once they go home to their villages for more physiotherapy, or to their town. So looking at continuum of care and levels of care to continue treatment. And I'm saying physiotherapy, I'm sorry, because I'm a physical therapist, but rehabilitation care. Okay. Leadership. And I think you know, aspects of leadership can be incorporated into most classes. And we're talking about how can we, you know, why it's important to document, what we can use data for. So just a little bit of leadership training, why people should be accountable, looking at professionalism, sharing. That is often not a culture of sharing of knowledge and information. So talking about those things, maybe giving examples, like in some countries, you know, like for instance, the United States, it's kind of normal if you go to a CPD course to share that information with the staff when you get back. And that's not the case in a lot of other countries. Sometimes in other countries, it's more of a culture of holding on to that knowledge because it makes you more powerful to hold on to it. So just introducing different concepts about that. So of course, we could introduce the competency framework. It's up on the WHO site, and if you feel comfortable, if people are interested in it, kind of even talking about it or looking at that, it could be something that could be introduced. And also introducing the package of rehabilitation interventions when that comes out. Okay, so those are the main things, and how we can get a little bit in some about what Rehab 2030 is, why it came about, why it's important, and how health volunteers overseas can interact and kind of use some of the tenets of Rehab 2030 to strengthen our programs and to help other countries to strengthen the rehabilitation sector. Okay, I look forward to your questions, and I'm going to unshare the screen.
Thank you, Monika. That was great. So I'm here monitoring the chat. Does anybody have any questions that they'd like to put in the chat? Or we have a relatively manageable sized group. If you just want to unmute yourself and ask a question, we could probably do that as well. I have a question to start off with, Monika. It seems to me that as we look at HBO, as we look at planning projects going forward, not only in physical therapy, but in other rehab related arenas, that this would be having an understanding of this Rehab 2030 and its tenets and philosophy, and sort of integrating that into the site assessment process would be extremely valuable. Finding out if the country is involved. I don't think all countries are equally involved, if I'm correct on that. Correct. So is that something that you see that HVO could sort of add to our assessment process and should add? And what are there pros and cons or roadblocks, pitfalls that we should know about?
But so well, I think yes. So I would say that what we can do is, as The site assessment reports are finalized. They are on the WHO website and are open for anybody to look at. So we could utilize those and offer those to volunteers or to people that are coordinating the site to see where the countries are along the continuum of strengthening rehabilitation within the health system.
That's a great idea. So a question that we have from Rick Black. Oh, sorry.
Oh, I was just going to say another, I think one little key indicator that can be used is just asking, is rehabilitation mentioned in the Ministry of Health strategic plan? There are many countries where rehabilitation is not even mentioned, like it doesn't even exist in the Ministry of Health. So that'll give that's like a quick down and dirty indicator of where it stands, within the Ministry of Health. Right.
Very often it's in a completely different ministry.
Right. Can be.
So Rick Black has asked if you're aware of any programs to help pay for the education of healthcare professionals in lower income countries.
I mean, I think countries do have scholarships and programs that are available. So I don't think there's one, but I would go, depending on where, what country he's working with, you can check and see what's available. So I know often they're through different countries. Like I know I was just doing the assessment in Belize, and in Belize they had some people being paid for by their government to study in Japan or in Canada. So often it's through their own government. You can look at that.
Right. And Julie Gayheimer, says, how can a former HBO volunteer get involved in this WHO initiative?
I would say right now that is to attend the rollout. So if you can get on the WHO, well, you can go to WHO, their site, and what you can do is just Google WHO Rehabilitation 2030, and you can sign up for, I think it's next week, they're having a training on the competency framework. And actually Cheryl Footer is one of our long-term volunteers, is going to be a featured speaker at that training coming up. And they're also the trainings as the ones that have already happened. I was just spoke at one last week on the framework that they'll be online. So you can find anything online. And so that is a way to learn about the initiative and become a part of it. All of the materials you can utilize in if you're at a site, their WHO's, all their materials can be utilized by the public.
Robert?
Yeah, thank you, Monika, for your presentation. I have a question on I have a question on how to maintain these programs, because most often than not, the maintenance of these strategies is dependent on the policies that exist, for example, in the remote areas of government and the ministry. So how far is the ministries and government agencies involved in making sure those in the remote areas do get access to rehabilitation? Because I happen to work in a hospital where you have people traveling about 250 kilometers to come see you for a day and then go back.
Yeah, good question. Which country are you speaking of in particular, or just in general?
Ghana.
Okay, yeah. So yeah, and this comes up a lot, and again, I think you're pointing to the aspect that it is a systems issue, right? So first, we need the Ministry of Health to prioritize rehabilitation, and Ministry of Health needs money to support rehabilitation. Where do they get that from? Is the central government. So we can look at like how much does the central government, how much of their GDP goes toward healthcare, right? And then of that, that's divided up. So we want to get a part of that used for rehabilitation. So part of it is having more funds for rehabilitation, and then utilizing those to make sure that people are trained correctly and that hospitals and sites are staffed. Now, sometimes that's just not realistic. You know, in poor countries, they do need to prioritize. Maybe they're looking at, right now they're prioritizing COVID, right? And they can't give money to rehabilitation. So that's when we need to look at more creative strategies. Some of the strategies are called task sharing. So that happens at the rural areas, like where you said, if people have to travel for hours and it's expensive and arduous, they're just not going to get the rehabilitation care. It's not available or accessible to them. So that's when things that are less expensive, for instance, task sharing is when, if you can train rehabilitate community health workers or people that are working in community-based rehabilitation and some basic rehab interventions. So train them in maybe how to gait training with crutches, or train them in, you know, basic interventions for back problems, your basic exercises, but training other people and sharing those tasks when we know, if you know in your country, there's just not enough therapists to reach those outlying areas, right? So something else creative and less expensive needs to be done. So that's just an example of looking at a different way to increase rehabilitation, access to rehabilitation in outlying areas. And I think it comes down to what you're talking about with the Ministry of Health and the government is advocacy. So it's organizing, you know, if you have a physiotherapy association, if you have a college of physiotherapists, you know, any kind of union of physiotherapists, and learning a little bit about advocacy as well, to advocate so that people know, not only in the, you know, looking at within the health system, but also the general public understands the importance of rehabilitation. Does that answer your question?
Yes, please. I wanted to add one more suggestion concerning the referrals and then also increase the capacity of those specialists to see these patients. For example, in my hospital, I realized that going to these old folks to talk to them about early referral I see most of the hand patients is difficult. So what I was doing was to rather approach the younger residents and the medical students. So once they get out of the training, by then they have already had a concept of,
really smart.
and most of them, yes, most of them are able to get their postings to these remote areas. So once they have this knowledge, they know at this point, this patient had to see a therapist, either occupational, either physiotherapist, either speech therapist. Because if we don't catch them young at that level, when they grow, that they will just act like they are senior folks. And I think that has been very helpful. Now we have trauma residents coming to do rotation in the physical therapy department so that they get to know what physios do and what they can do as early as possible to bring their patients in.
Really smart. I think that's a great strategy. And I think what we've seen a lot, or what I've seen, is often rehabilitation is thought of as the last resort. So maybe somebody's been in a motor vehicle, has a motor vehicle injury, and has fractures, and they aren't sent to physiotherapy until they have contractures, right? They're thought of as, and then we're supposed to cure them, so it's at the very end. Oh yeah, well, nothing else has worked, So for people to realize when it's appropriate to, that it's not a referral of the last resort, but that it's needed at the beginning. So I think those are really good strategies you brought up too. Thank you.
Any other questions? I was struck, Monika, by your comment at the beginning about how the needs outstrip the demand and the supply. I mean, the demand is low, the supply is low, but the needs are significant. Mm-hmm. And it just seems to be so out of whack. Especially the part about the demand being low too. Is that really lack of knowledge on the part of the public?
Lack of knowledge, lack of acceptability, meaning that, some places use traditional faith healers, or they in some societies they think more, about injections and pills curing everything, right? There's a lot of that too. People think, I want a pill for this, or I need an injection to be better. So that's called acceptability and lack of acceptability for physiotherapy. So there's some of that too going on. And also there's decreased demand. I mean, there's some countries still where people have a child with congenital issues, they hide that child, or they think that they're not supposed to get rehabilitation for that child. That child is their punishment for doing something wrong, and so it's wrong to seek out rehabilitation. There's all sorts of reasons why people don't seek out rehabilitation care. And that's another, function for community health workers and people working in community-based rehabilitation. If they're going in villages house to house and try to talk to people one-on-one about the stigma associated with people with children with disabilities, or also to just increase awareness of, hey, you have something that maybe the grandparent had a stroke, or they're limping, or they're not using the correct assistive device, and to just, there's a community-based rehabilitation worker that can say, hey, why don't you try rehabilitation? That can help you with this, something they might not have even thought of rehabilitation, and just need somebody to help them along that path. So those are reasons for decreased demand.
Yes, Ronnie.
I had asked a question that Robert also alluded to. I'm a big believer in the CRW, the community rehabilitation worker or community health worker. And I wondered how that model was moving forward. I know during AIDS, which is already a long time ago, many of those programs were dismantled because all the attention went to AIDS for a while. But I really believe that at this point, although professional education is very important and we need to work on that at the same time, that most people will be reached through CRWs. And I wondered how that was going and if there were any model programs.
Yeah, it's very country by country. And I think a lot of the programs are not national. There'll be an NGO, maybe a religious-based NGO, maybe just a local NGO that works in one region or works in a few regions. Or like in Guatemala, there's several NGOs kind of based in several regions. Now they're trying to get together, but they're small regional programs. And sometimes also people think of community-based rehabilitation to be most applicable to rural areas, which is important, but also in urban poverty areas, they're just as important. People still, they can live in an urban area, but if they live in an area, of a very low income area, there's rehabilitation is still not accessible to them. So they're crucial, I agree with you, in both regions, and there's a big piece of the puzzle. But yeah, we haven't, I think, 20, 30 years ago, we thought, oh, this is going to be the answer, but there just hasn't been the growth that I think a lot of us would have liked. And also there's been this kind of rehabilitation based in the community isn't always about offering rehabilitation services like physiotherapy, speech therapy. It's more about advocacy for people with there's that matrix. It's a lot about advocacy, education, important things, your job training, but doing the actual therapy is a small piece of that. So sometimes it gets lost a little bit. So they're looking at even kind of renaming that or pulling that out. So it's often people that aren't just workers that are just trained in rehabilitation, but people that are community health workers that learn a little bit about rehabilitation too. Yeah.
Here's another challenge that we have here, Monika. So sometimes we have these rehabilitation specialists who wants to go to these communities who are very deprived to work, but then they get there and they realize that common amenities like good water, food, school, road is inaccessible. So this kind of discourage people who are not living in these remote areas from going there to work because they realize that, I mean,
Oh, yeah.
living in such environments to work is nearly impossible. And for some, of course, you are in these remote areas and are taking the same amount as somebody who is living in a big city. And it's very discouraging to work there. Yeah. And realize that sometimes there's absolutely even nothing to work with, right. But you want to do what is expected of you.
So there's some countries that have, and that's true throughout the world. People want to work in the urban areas and not the rural areas in general. And there are some strategies that different countries have employed. One of them that some countries use is that all graduates need to complete 1 or 2 years of community service, and so after you graduate from occupational therapy program or physical therapy or whatever, you're assigned to an underserved area. So some countries do that you're required. Other countries have incentives. So if you work in a rural area, maybe you're paid more. Other countries, they just place workers. You don't have a choice where you go. You're placed by the Ministry of Health. Some countries you get a scholarship if you promise to go back and work in the village where you came from. So there's a lot of different strategies. They haven't all been successful, but some of them I think are helping with that. And I know that is a big problem. It's just not enough workers in the rural areas. But it's interesting to look at different strategies and what works and what doesn't, and how successful they are.
It's a problem here in the States too, isn't it?
Yeah, we have
maldistribution. I mean, it is, when you say it's worldwide, you truly mean worldwide.
Yes. Uh-huh.
Another possibility is parents of people or children of people with disability. They're more inclined to stay local. Maybe there's a way to incentivize them to learn what to do.
Yeah. Teaching's a big part of it. And there's I was just interviewing somebody in Guatemala, and they have, I mean, you could call it community-based rehab, but they go out, they work in these rehabilitation centers for children, but they go out and do visits to the rural areas, but it might be once every few months or something, but at least training the parents. So and that's kind of that is a form of community-based rehabilitation. I think an important piece of this too that we haven't talked about yet is the gatekeepers. So gatekeepers are people that, when you first, it could be a community health worker. It could be when you go to your local primary care facility, the person that you see, which often is a health work, a community health worker, that they know to refer you to physiotherapy or occupational therapy or speech or whatever, because often they don't know. So those gatekeepers have a lot of power, to refer you on or not. So it's training of the gatekeepers too. They might not do physiotherapy or do occupational therapy or another rehab service, but they need to know when it's appropriate to refer to rehabilitation services. And that's an area that, if we don't get that, we're missing a lot of the population, right, that need it.
All right. Well, thank you, Monika.
You're welcome.
I think this has been very, very interesting. We will send you all an email, if not this afternoon, on Monday, and we will include all the links to the WHO Rehab 2030 various frameworks and competencies, etc., so that you have that.
Right.
And if you have any follow-up questions, just shoot me an email and I'll pass it on to Monika. And I thank you very much. Thank you.
Thanks so much.